It's a summer morning in 2015, and somewhere in the South Bronx, a single case report lands on a public health investigator's desk. Legionnaire's disease. Not unusual for July in New York City, but then another case comes in, and another. What starts as routine surveillance quickly becomes a major outbreak investigation. The kind that tests every system that Dr. Weiss describes. This is the hidden world of disease detectives, the epidemiologists, surveillance experts, and public health warriors who stand between us and the next pandemic. They work in a complex web of federal, state, and local authorities, armed with statistical models, laboratory networks, and a systematic approach that can trace an outbreak back to its original source within days. But what happens when politics collides with public health? When mayors and governors turn disease outbreaks into a political theater? And how do these modern-day detectives actually solve the mysteries that could threaten millions of lives? From PHI Media, I'm Gordon Thane, and what you'll hear is a conversation between LaShawn and Dr. Don Weiss, a conversation that reveals the fascinating and sometimes troubling reality of how America responds to disease outbreaks, and everything in between. You're listening to the Public Health Insight Podcast, your go-to space for all things public health and global health, from the Sustainable Development Goals to the social determinants of health, as well as interesting dialogues about the diverse career opportunities that exist in these fields. Remember to subscribe to the podcast and leave us a rating on Apple Podcasts and Spotify so other people like you can benefit from our content. The 10th Amendment of the U.S. Constitution is just 28 words long, but it fundamentally shapes how America fights disease. Unlike countries with centralized health systems, the U.S. delegates public health authorities to states, creating a patchwork of 50 different approaches to everything from disease surveillance to outbreak response. It's a system that can be both remarkably agile and yet frustratingly fragmented.
Many people don't realize that public health authority flows from that 10th Amendment and that states get these powers because the Constitution doesn't explicitly give them to the federal government. So with this in mind, and I know obviously there's many states, how are state-level public health systems organized, and what specific powers do they actually possess?
Well, having worked in two states, I can sort of talk about those, and I'll start with New York State. So there's something called home rules, which is another, it's not codified anywhere, and that gives the New York City legal system, the New York City municipal government, able to pretty much run a health department separate from the state. So we were essentially like a small state, New York City. Now, we could be stricter than state regulations, but we couldn't be less strict.
Right.
And that did sometimes put us in conflict with the state. And not so much that it was the health department conflict, it was governor and mayor conflict, which then trickled down to the health department. Now, New York State has a lot of county health departments, and they more function like satellite offices of the state. And now we all get funding from CDC. That either gets passed direct, like New York City would get funding directly from CDC, and all those all those local health departments would get it funneled through the state. The way it worked in Missouri was similar, except the state had greater control and the city of St. Louis had less control. One of the things I fought very hard about, it took me lots of sleepless nights, is that both Kansas City and mostly St. Louis had the bulk of lead-poisoned children. But what the state sought to do was distribute the money pretty evenly over all the counties. So you're looking at counties that might have, a few thousand children, out of which maybe a half dozen were lead poisoned. And then you have a city which had 20 or 30,000 kids lead poisoning, and the distribution of funds were not equitable. So that's a situation that you have to be concerned about and fight for.
What Dr. Weiss is describing here isn't just bureaucratic complexity. It's a fundamental challenge in American public health. The Centers for Disease Control and Prevention provides guidance, but the actual authority to investigate disease enforce regulations, and allocate resources rests with the states and localities. Take New York City's Home Rule Authority. It allows the city to essentially operate as its own health jurisdiction, with direct federal funding and the ability to set stricter regulations than the state, while the smaller jurisdictions can often depend heavily on state-level decisions.
I could imagine, based on this 10th Amendment, it seems like, sure, states do have these powers, but it seems like they have the discretion to kind of further organize how that actually looks in practice. At the county level, what that looks like. At the state level, what that looks like. The funding distributions might be different state to state. And I guess the organization in terms of, are they centralized health departments or decentralized health departments, and the connectivity behind that. So yeah, I definitely can appreciate the complexity behind the arrangements and structure of that. You were the director of surveillance for the Bureau of Communicable Diseases, the BCD, at New York City Health Department.
Correct.
I want to pull back the curtains a bit on New York City's public health structure, from the different units or teams and the various roles that make the work possible. What do epidemiologists do, and what are the other crucial roles at the health department that help kind of contribute to healthier communities? What are some of those different roles?
Yeah, so the health department, you have a commissioner's office, and then we have divisions. The division I was in was called disease control. There's a division of environmental science, administrative divisions. And then within the division of disease control, there were a number of bureaus: the public health laboratory, immunizations, tuberculosis, HIV and AIDS, sexually transmitted diseases, and the Bureau of Communicable Disease. We were sort of while all those diseases had maybe 5 to 10 diseases, we had close to 90.
Wow.
And any new disease that came along, like West Nile in 1999, pox, Zika, all those new diseases, they would by default come to the Bureau of Communicable Disease. We were always increasing our diseases. So epidemiologists throughout the health department have slightly different roles, but they could be conducting research. So we're looking at the data that we collect. Surveillance means that we're collecting data. It's authorized by law. Sometimes they're doing special studies. So there's a division of epidemiology that does surveys of health in the community, which are very important in deciding where to spend funds and where to put research and other efforts in prevention. In our bureau, those epidemiologists are really looking at our data. We try to track diseases, determine where they're going, most of their work, though, the epidemiologists' work there, is whether we're experiencing an outbreak and we don't know about it. So you could have a background level disease, which is called endemic, of, maybe 2 or 3 cases a month. So you might not think that's an outbreak, but if those 2 or 3 cases are all concentrated in one area of the Bronx and not throughout the city, you might have an outbreak there. So we had a lot of statisticians and epidemiologists who were working on statistical analyses that could use time-spatial parameters and try to find new ways of detecting outbreaks.
The Bureau of Communicable Disease represents something unique in American public health, a center tracking nearly 90 different diseases in real time. While specialized bureaus handle major diseases like tuberculosis, HIV, and sexually transmitted infections, the BCD kind of becomes like a catch-all for everything else. This matters because modern outbreak detection depends on recognizing patterns that would be invisible to individual doctors or hospitals. When disease reports come in from across the city, epidemiologists run sophisticated analysis to distinguish between normal seasonal variations and genuine outbreaks. The epidemiologists that Dr. Weiss describes aren't just counting cases. They're using statistical models to map disease clusters, analyze geographic and temporal patterns, and building the surveillance infrastructure that makes rapid disease detection possible. It's detective work powered by public health science, and it's what allows health departments to spot problems before they become disasters.
Wow. And do these epidemiologists work closely with other roles within the health departments? Like, is there a role for public health inspectors or public health nurses?
Yeah, so I could talk mostly about the bureau that I worked in. we had public health nurses and they were investigators.
Yeah.
So whenever a case would come in, meningococcal is a good case. That's a serious bacterial infection that can cause either blood poisoning or meningitis. They would investigate that. And the reason for investigating meningococcal disease is because there's something you could do about it. You could offer the close contacts antibiotics, which will prevent them from getting sick. And that's a time limited thing. You got to do that within 5 days. So that's what our public health nurses would do. We also had what are called public health epidemiologists, which are mostly masters trained staff. So they would do investigation on some of those other diseases, such as typhoid fever, tick-borne diseases, all the enteritis diseases. And so they would do those investigations. The epidemiologists work with them to help them collect data, to analyze the data, to produce reports, and to make decisions on what we need to do based on the data.
Wow, yeah. No, that makes a lot of sense. And I guess to kind of better understand where you all were situated doing your work, I think you've been on the record of calling New York City the epicenter for outbreak work, and beyond kind of the obvious 8.3 or so odd million people packed into the 5 boroughs, what other factors make the city uniquely challenging and fascinating from a disease detective's perspective?
Well, it's densely packed. So I think 300 some odd square miles, and you have 8 million there. It's one of the highest population densities in the world. And it's a destination area for travelers. So you have people coming from all over the world. One of the stories I relate in the book happens to do with a colleague of mine who was at a conference. This is back in 2002, in the fall of 2002. He was sitting in the back of the room, which is what his predilection was due. It was a conference of infectious disease physicians. He was sitting next to a physician from Singapore, and that Singapore had SARS.
Right.
And he had come off, he had gone back home, left the conference early, got pulled off the plane in Germany, and was rushed to a hospital there. So my colleague certainly could have contracted SARS because he wasn't probably sitting away too far from that individual. So it gives you an idea that, we're never more than a few hour flight away from an epidemic.
Yeah, no, for sure. And I mean, with all the travel and kind of the shrinking of the world due to like globalization and different technologies, I'm not surprised that there's more kind of transmission of diseases that you wouldn't otherwise see endemic to the United States or Canada. I'm thinking of potentially neglected tropical diseases. You see them in subtropical areas in different countries, and because of travel, sometimes you could get some of those cases come over and we might not expect it because it's not native to where we're situated in with our public health capacities.
That's how West Nile was. We never could figure out exactly how West Nile came to New York, whether it came in a suitcase with a mosquito or a bird somehow got smuggled into the country. So that reminds me to tell you that it's not just humans. It could be animals.
Right.
It could be animal hides. We had an outbreak, not an outbreak, but a single case of inhalational anthrax in 2006 in a person who made drums, and he imported his hides from Africa.
Wow.
And when we tested the hides, they were full of anthrax spores.
Wow.
And the other thing is food. There's food that's coming into the country from all over the world, and it could be contaminated as well.
That's right, yeah. And so sometimes when I watch these news coverage of disease outbreaks or listen to different public discourse about epidemiology, I wonder, you as an epidemiologist, do you kind of see things, concepts, ideas that the media consistently gets wrong? What would you most want to correct out of those kind of errors in concepts or definitions?
Yeah, my biggest pet peeve is the word quarantine.
Yeah.
So reporters will use quarantine in absolutely every situation. When someone came back from school and they were quarantined. So quarantine is something we do to people who are well. They don't have any signs of illness. We believe they've been exposed to an illness. We want to keep them in a location so that if they should get disease, they can't transmit it to anyone. It's a way of stopping the chain of infection.
Yeah.
But, if someone goes into the hospital with tuberculosis, they're being quarantined. Well, no, they're sick. They're being isolated.
Right.
We isolate the sick, we quarantine the well who've been exposed. So yeah, that's the biggest one. I mean, there's certainly a number of them, but that's the one that most often crops up.
Interesting. Yeah. I want to get into the nuts and bolts of outbreak response now that we kind of have this idea of isolation versus quarantine in our heads. What are some of those foundational elements that have to be in place even before you begin to investigate? Like, what's your toolkit look like?
Yeah, so you have to have staff who are trained, of course, and you have to have a good laboratory system.
Yeah.
We were fortunate in New York State that we had a local laboratory that was quite good, and our state laboratory, Wadsworth Center, is probably one of the best in the world as far as state laboratories. Not only did they provide a lot of service, they also developed tests.
Right.
So they developed one of the tests that we used during our Legionella outbreaks, where we could quickly send a water sample up there, and they could tell us whether or not Legionella of the species we were worried about was actually in the water. So those are the two foundations of that. The third, of course, is surveillance. So you're not going to detect an outbreak unless you're knowing about whether or not there are cases of disease. Now, surveillance only works if the disease is something you've diagnosed in the past and you've passed a law to make it reportable. It doesn't do so good for a new disease in which nobody has a way of diagnosing it or even describing it, such as when SARS arrived in 2002 and 2003. It took a while before people could come up with a test for it and a clinical description so you knew what you were dealing with. So that's sort of the foundation.
Dr. Weiss touches on something crucial here, the fundamental limitation of disease surveillance. The system works well for diseases that we know about, have tests for, and have made legally reportable. But what about completely new threats? SARS exposed this vulnerability in 2003, arriving as a novel coronavirus with no diagnostic tests and unclear symptoms. The same challenges exist today with emerging diseases. Surveillance systems can only detect what they're designed to look for. The Wadsworth Center that Dr. Weiss praises represents a critical piece of this infrastructure. Recent reports show that the Wadsworth Center was key to the New York City strategy in controlling COVID-19, including by analyzing wastewater and using genetic sequencing to identify new variants. The laboratory is one of only 7 in the US designated by the CDC as antimicrobial resistance regional laboratories. Giving it specialized capabilities for rapid detection, the center's rapid testing capabilities allowed investigators to identify contaminated cooling towers quickly. This lab network, combined with modern genomic sequencing and data analysis, gives today's disease detectives capabilities that previous generations couldn't even imagine. But as Dr. Weiss notes, the system still depends on trained staff, adequate funding, and the political will to act on scientific evidence.
I could go through the steps in an outbreak if that is of interest.
Absolutely of interest. I mean, like, you don't have to be an epidemiologist to want to know how you could respond or support the work that epidemiologists are doing. So, whether you're an aspiring epidemiologist listening to this podcast or just curious, like, I would love to walk through your systematic approach. And obviously, you bring the 23 years of experience in this field. So please do walk us through your playbook. Let's go.
Sure. So I'll start by telling folks that the process of investigating an outbreak is very similar to what criminal detectives do when they're investigating a case. There's a lot of similarities between the two. So the first thing that we would do is you have to confirm that it's an outbreak. So that's where surveillance data and understanding of the disease and the locale are important. For instance, a single case of anthrax in New York City is considered, in a human case, is considered an outbreak, whereas maybe a single case of plague in New Mexico, where it's endemic, it circulates in rodents and prairie dogs, and sometimes spills over the human population, it wouldn't constitute an outbreak there. So let's say you've looked at your surveillance data. Probably Legionella is probably the best one to use as an example. You've seen a cluster of cases in a location of the city. You compare it to the past. That's why it's so valuable to have surveillance data. Say, well, what happened last year, the year before that? Say, well, if we only had per month 2 cases here, and all of a sudden we've got 20 in the same time period, that should trigger a response. All right, so once you confirm that there's something going on, you're going to gather your team.
Yeah.
So you're going to pull some people together. You're going to assign them tasks. You're going to need people to collect samples. You're going to need people to review medical records at hospitals, people to interview physicians, interview patients. You're going to need the laboratory on board to test both human specimens and environmental specimens for Legionella, because it's an environmental bacteria that affects humans. And then you're going to start collecting cases. You're going to communicate fairly soon in the process to the community what's going on. That communication has to be ongoing, so you're going to tell them, give them frequent updates. Now, this has twofold. One, you're telling people what they can do to protect themselves.
Mm-hmm.
So if you know there's an exposure at some location, you might tell them to stay away from it. Or there's a food product out in the community, you tell them throw it out, don't eat it. The other aspect of that is that we'll get the physicians involved. Marcy Layton created this physician alert system where we would tell physicians, hey, here's what's going on. We're looking for Legionella cases in your community. Here's what to look for. Here's how to report. And then we're compiling all this data and we're analyzing it fairly quickly. We're mapping it to see what the area that's affected. We're describing the illness. Is it acting like Legionella normally does? Is it acting in different ways? Are there specific risk factors? Legionella is a risk factor for people who have chronic lung disease, smoking, diabetes. They're all risk factors for Legionella. So it's important to get out to the community. Hey, if you're the type of person who has asthma and you start to get symptoms, don't wait. You know, Legionella is one of the diseases you got to get treated right away. If you wait, it might be too late.
Right.
And then at some point, we're looking for the source, or not some point, that's the whole point of Legionella investigation. We're looking for the source.
Yeah.
Once we find the source, we're remediating it, and then we're checking to make sure it stays remediated. Once we get towards the end of the outbreak, you're compiling your report, you're putting together, of course, it's in the public domain. People can look at the report, it's part of the government. And then we do ongoing surveillance.
Yeah.
So not only have we decided that an outbreak happened in the Bronx of Legionella, but we're making sure that it doesn't recur by monitoring surveillance data. So that's sort of the outbreak investigation in a maybe a walnut-sized nutshell.
No, that was fantastic. Thank you for going through that. And typically, I'm assuming it varies per kind of outbreak, but could you give a sense of some of the timelines and of how long these things take? Because I imagine there's so many things happening so quick, and time is obviously of the utmost importance here to make sure we're protecting the community. But do you have a sense, given a lot of your experience, like what does that timelines look like for these things?
Boy, it varies.
Yeah.
So Legionella, we detected the outbreak. This is going back to 2015. It was sort of maybe the last middle of July. We started to see cases creep up. We started in earnest sampling cooling towers because cooling towers are the most likely source for community Legionella. These are engineering devices that provide cool air to buildings. So you might have your portable air conditioner that air conditions your apartment.
Yeah.
But for a very large commercial building, you need a more durable system. So it was probably the end of July when we started to do that. Within 2 days, we had found the putative source and we started to ameliorate it. So it was somewhere around the 28th or 29th, we sent out teams. The lab turned around quickly. By August 1st, we were in there remediating. It took a little bit longer to prove it was the source, which it ultimately did. Then there's outbreaks that smolder on for a long period of time. Take the surveillance that we did for the Ebola outbreak. It took years, even though we only had a single imported case in New York City of a medical worker who had volunteered in Africa. We were doing surveillance of people coming back, because there's a lot of travelers that came back from that area of Africa, and they get sick, most likely with malaria, but we had to check to make sure. The anthrax outbreak took a long time too. That was something we played a supportive role. The main investigative group was the FBI, but we were doing the public health investigation, and that took a long period of time.
Going back to one of your Insight Blitz answers, you kind of highlighted the role of politics, and we want to prioritize the health rather than getting too caught up in politics here. So in this kind of outbreak response or disease outbreak, the systematic approach that you outlined here, surely there's been situations where politics come to play and maybe affect, influence, and alter some of this process here. Do you have an example in mind where politics perhaps hinders or blocks some of these public health efforts that we have going on?
Well, we already mentioned what happened to Mpox,
Yeah.
where politics muddled the messages that prevented that going out. But the other one that stands out of mind, sticking with Legionella, was the same outbreaks in the Bronx.
Yeah.
So I mentioned within a couple of days we had found the putative source. And the outbreak was limited to the South Bronx. It was sort of like maybe a 6 zip code area where cases were occurring. But what the mayor did, he ordered all the inspectors throughout the health departments. You had food inspectors, you had lead inspectors, you had all sorts of inspectors who out of other responsibilities. So their jobs were to prevent diseases other than Legionella. Ordered them all to check every cooling tower in the city.
Wow.
And the director of the division said, no, this is a waste of time and resources. We don't need to check Coney Island. We're doing routine inspections, but we don't need to pull all of our food inspectors too. We don't need to pull all of our food inspectors from everywhere in the health agency and send them out to do useless ones.
The 2015 Bronx Legionnaires outbreak reveals something about the strengths and vulnerability of outbreak response. As he explains, his team's systematic approach worked. They detected the outbreak, identified the likely source within days, and began remediation by the end of July. The scientific method was sound, the response was rapid, and the remediation was effective. But the political response was problematic. Mayor de Blasio's decision to deploy food inspectors and other health department staff to check cooling system towers citywide wasn't just inefficient. It actively diverted resources from the focused public health response that was already working. When Dr. Weiss mentions that the outbreak was geographically limited to about 6 zip codes in the South Bronx, the citywide response becomes even more questionable. The competing press conferences between city and state officials, where test results were announced before the patients even were notified, represents a breakdown in the basic protocols that public health depends on. This tension between political expediency and scientific rigor would become a defining feature for larger health emergencies down the line.
He also wanted us to break down doors, which was patently against the law. Our lawyers said, no, you cannot do that. And so that was something where politics came in clash with what public health policy was.
Wow, yeah, it gets complicated. It surely does. And I think when I was reading some sections of the book, in that instance of Legionella, it was talking about, maybe it was a different outbreak, it was mentioning how at some instances, some of those government figures wanted to be the first to report on some of these outbreaks and some of this data, sometimes even before the patients even know if they had contracted a disease.
Yeah, that brings back to what I mentioned before, that you had this conflict between the governor of New York and the mayor of New York.
Yeah.
We commonly called it a pissing match. And they were constantly trying to one-up each other.
Yeah.
You know, one had a scheduled press conference for 11 o'clock, the other one scheduled theirs for 10 o'clock.
Wow.
And what Governor Cuomo did is he ordered, so normally the process would be, if we collected a sample and sent it to the state, sent it to our health department, which shipped it to the state would get the result, they would send it back to our health department. If it was a patient sample, they would notify the patient. If it was an environmental sample, they would send it back to us. Yeah. And then from us, it would work its chain up the line to the commissioner, right, same as it would work its chain up to the commissioner in New York State. What Cuomo did, he said, no, you're not going to do that. All results come to me directly.
Wow.
So if there are results in New York State, didn't matter, New York City, they came to him. And so he would rush to make his announcements. You have a third case, or fourth case, or fifth case. And there were situations where the patients had not yet even been notified.
Wow. Yeah, definitely muddy. Definitely very muddy here.
Well, it brings to mind that the conflict between what is public health's goals and what are politicians' goals. And if they don't align, which very often happened during COVID, for instance, and especially during Legionella, where's the public left? We haven't talked about this, but there has been a decrease in trust in public health by the public. And a lot of it has to do with this conflict, both covert and overt, that has happened between politics and public health.
The conversation you just heard reveals a delicate balance between science and the politics that defines American public health. Dr. Weiss's 23 years of experience shows us that systems can be remarkably effective when it works, detecting outbreaks within days, tracing sources with scientific precision, and implementing interventions that save lives. But we've also seen how political interference can undermine even the most sophisticated public health response. Coming up next, We'll dive deeper into the mysterious stories themselves, the strange cases, and the bizarre outbreaks that challenge even the most experienced disease detectives. That's next time on the Public Health Insight Podcast. This show was edited by me, Gordon Thane, with additional editing from LaShawn Benedict. Sound design and mixing by myself and LaShawn Benedict. The original music from The Music Room, composed by Tom Fox, licensed from Johnny Harris. The cover art design for our show by LaShawn Benedict. The Public Health Insight Podcast is produced by PHI Media. Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our podcast, be sure to subscribe and leave us a rating on Apple Podcasts or Spotify. See you in the next one.